Yes.
So I'm going to now give you a brief update on the diagnosis and management of painful diabetic neuropathy. These are my disclosures. So painful diabetic neuropathy, we're all aware, is this condition which previous studies have actually shown, which have been from Europe and the US, have shown that 1 in 5 individuals with diabetes will get this condition, which is pain in the extremities, worse at night, characterized by pins and needles sensations, electric shock-like sensations, shooting, burning sensation, but also some numbness. So that was really studies from the Europe and US. Now, what are the studies like in this part of the world? Well, we actually did a study from Qatar where we looked at over 1,000 individuals with diabetes, and we actually showed that the prevalence of painful diabetic neuropathy, as assessed by the gold standard tools that I'd been previously using in Manchester, was actually 34%, higher than we'd found previously in Manchester. So why was that? Well, one of the main reasons was actually that a major risk factor for painful diabetic neuropathy is obesity. And that is highly prevalent in Qatar and in the Middle East. So that is a major risk factor, and smoking as well. So those are major risk factors for painful diabetic neuropathy, increasing the prevalence. But the most important finding is this, that actually 80% of these patients that we had now diagnosed from primary and secondary care had not previously been diagnosed. And that to me was shocking, because I thought, this is terrible. Maybe in this part of the world, we just don't have the time, or we don't ask the questions. But actually, if you look at the literature, it's across the world. Diabetic neuropathy is just not diagnosed. So undiagnosed diabetic neuropathy, you can see whether you look in Qatar, which is 80%, even the USA, 79%, Thailand, 65%, and other places like Germany, 91%, Saudi Arabia, 98%, are just not being diagnosed. So are they not being diagnosed with the painful diabetic neuropathy or diabetic neuropathy because, we're too busy? Or maybe we haven't got the tools to help us to assess this quickly and efficiently. And that's where really we've now started to look at maybe trying to make a change. And what we're suggesting is a newer, simpler screening tool for painful diabetic neuropathy particularly. And this has been put together through an expert panel from over 18 countries. And what we essentially did is we looked at all the questionnaires that were currently available, including LANS, DM4, MPQ, Pain Detect, ID Pain, and clearly they all perform very well in clinical research studies. So they all have sensitivities and specificities which are above 70%. But the reality is that in the clinic, we just don't have time to apply any of these tools. And so we thought, well, what are the key features and how quickly can we maybe assess patients? And so we thought, okay, first of all, you need to have some way of capturing the main symptoms. Then you need to know something about the severity, whether or not it is worse at night, and whether or not it's symmetrical. And so if you apply that together with very quick sensory testing, right, which is assessment of pinprick and cotton wool, then actually the ACT tool, that as we call it, you can do in 2 minutes, 20 seconds, versus what everybody wants to use or maybe is endorsed, which is the MNSI, which actually, if you do it in clinic, takes over 14 minutes. So far, we've actually now got actually close to about 500-600 patients, but this is a study, just shows you how a quick tool could be efficient. So this is 19 patients in my clinic where we've used the ACT tool and compared it to MNSI. We actually showed that when we do this, we get very good or reasonable Cronbach's alpha, which is the reliability of the tool, but we get a sensitivity of 82% and a specificity of 78% for identifying painful diabetic neuropathy with this tool compared to the gold standard tools like the MNSI. So based on that now, actually, with the International Diabetes Federation, through funding from Procter & Gamble, we are now validating this tool in probably actually is going to end up about 3,000 patients, but in Qatar, Thailand, India, Brazil, Ecuador, and I've already been asked whether or not we can do it in Pakistan and in the Philippines. So hopefully, inshallah, we'll get this validated and to be used in the clinic. So beyond that, of course, I have to talk about, what is the underlying pathophysiology of this condition? Well, we know that the underlying pathophysiology is damage to the small fibers. And these are the small intraepidermal nerve fibers which get damaged, and both damage and repair actually is what signals the pain. So why are we not diagnosing this condition? Well, the simple answer to that is that the tests that we're doing in our clinics are the wrong tests. We have small fibers that are damaged, and yet all the clinical neurological tests that we do, whether it's neurological examination, monofilament, vibration perception, nerve conduction, what do they measure? Large fibers, which is not the small fibers which we should be measuring if we're going to get any handle of what's happening in terms of pain. Now, there are, of course, quantitative sensory tests, small fiber testing, but I want to just quickly share with you a tool that is maybe some people say is not widely available, but I can tell you there are 2 centers in India that have got it. There's a center in Pakistan. In Qatar, unfortunately, we have actually got 5 of these microscopes, but it does assess small fibers very quickly. And in fact, what you can do is literally look into the eye and measure nerve fibers. And when we do that, what we have are data, compelling data to show that if you do take people with painful diabetic neuropathy compared to painless diabetic neuropathy, compared to healthy controls, there is a consistent loss of nerve fibers, small nerve fibers in the cornea in like 4 different parameters. And furthermore, there is actually a relationship between severity of pain and the extent of loss of nerve fibers. So the more severe the pain, the greater the loss of corneal small nerve fibers. But is there anything we can do for diabetic neuropathy or painful diabetic neuropathy, or do we just diagnose it and then say, well, I'm sorry, but you've got this problem, but not much we can do for it? Well, if we look at the targets for painful diabetic neuropathy, there are 3 main targets. One is the periphery, which is where I believe the problem starts. Unfortunately, most of the medications that we use aren't really approved by the FDA for use in the periphery. So capsaicin works. Recently got an approval actually from the FDA. Local anesthetics, don't really use them either. NSAIDs and COX-2 inhibitors might work, but not really very effectively. But then we have the spinal cord. And the spinal cord, of course, we have 2 major pathways, which is the ascending pathways, which are going up to the brain. And here we have really the alpha-2 delta ligands like pregabalin, gabapentin, tricyclic antidepressants, tramadol, and opioids, which all work on this ascending pathway, blocking the passage of these pain signals up to the brain. And then we have descending modulation, which is actually putting a brake on these signals coming up the spinal cord. And this is, of course, through the SNRIs like duloxetine, tricyclics, tramadol, and opioids. But as you can see, the FDA-approved drugs really are working in the center as opposed to the periphery. And the latest trial data from the OxygenDN study actually shows us that all of these drugs seem to work, but not really that effectively. So amitriptyline is comparable to duloxetine, is comparable to pregabalin for the reduction of pain, but you only get 50% pain relief in about 50% of patients. And even when you combine the drugs, you only get another 5% benefit. So the question is 50% pain relief in 50% of patients enough? Can we do better? I believe there are better drugs actually, which we need to start to kind of understand their use and get them approved actually. So one such drug is crazugabalin, which is now approved in China, but not yet approved by the FDA in the USA. Why? Because the Chinese developed it. So what is it? Well, actually, this is an alpha-2 delta ligand modulator, but it has a binding affinity which is 23 times more powerful than pregabalin. So what does this mean? Well, if you take in a study, when you compare it to pregabalin, what you find is that overall pain relief, average daily pain score, is as good as pregabalin. But the effect that you get is much quicker with crazogabalin because of this binding affinity. So within days, day 2, day 3, you already get a separation with crazogabalin compared to pregabalin, compared to placebo. You can see pregabalin is taking about maybe a week for it to start to work, whereas crazogabalin works much more quickly. Then we have the new world of actually, well, it's an old world, but it's a new look at sodium channel blockers. Now, what are sodium channel blockers? Well, they're actually drugs that work on the periphery. So these are voltage-gated sodium channels, which is where the pain starts. And we've actually done studies now, genetic studies from the ProPain study, which shows that these are no longer the, 2% of the population might have this problem, but actually 21%, 1 in 5 individuals have variants, which are abnormalities in the genes that code for voltage-gated sodium channels 1.7, 1.9. And there are also smaller numbers, but nevertheless, there are patients with variants in genes that would modulate potassium channels and TRP channels. So ion channel modulation, I think, is going to be the new future, where I believe that when we modulate these peripheral channels, we will then be able to use higher drug doses without the side effects, the central side effects. And so we have now got suzetrigine, which has been approved for acute pain by the FDA just about 2 months ago, but we have also got ongoing trials in painful diabetic neuropathy. So this is actually gone head-to-head with pregabalin. And what you see here is that overall the pain relief actually is pretty comparable with pregabalin, okay, at that dose. However, what the big difference is that in the pregabalin group, you get the side effects. So you have weight increase, headache, dizziness, somnolence. But in the suzetrigine group, which is working at the periphery, actually very little side effects. And we also have now another class of drugs, which is the first of which is pilavapadin, which was approved, not approved, top-line data released in March the 5th, 2025. What are these group of drugs? Well, they're the adaptor-associated kinase AAK1 inhibitors. These block endocytosis and actually work on alpha-2 adrenergic signaling, which is a major modulator of pain. There is a study of about 500 patients, the PROGRESS study, which allowed the use of pregabalin, gabapentin, and duloxetine, and this was an add-on. And this has just been published in Diabetes Care and basically shows that if you add this drug to people who are already on pregabalin, gabapentin, you get a further reduction in pain. But sometimes obvious conditions and treatments are the most difficult to grasp, and one of those is vitamin D. So vitamin D, we and others have shown, is lower in people with painful diabetic neuropathy compared to painless diabetic neuropathy, particularly if you have a level less than 20 nanograms per mil. You have a 9.8-fold increased risk of painful diabetic neuropathy. And to the rescue, we were talking about this, we should be doing studies in this region. And actually, with Abdul Basit, we did this study in Pakistan because I couldn't get funding for this to do this study in England. And what we did is we did a study with vitamin D3, 600,000 international units intramuscularly, followed up for 20 weeks. They had remarkably good vitamin D levels, 31 nanograms, which most people wouldn't treat. But when we treated it, it went up to 46 nanograms. But look at the pain. Total McGill pain score came down significantly. It's as good as pregabalin, as gabapentin, as capsaicin. And that we improved the quality of life. So, and lastly, B12, which actually, when I came to this part of the world, everybody's on B12. And I wondered, why are they on B12 if really the evidence at that time was pretty, I would say, tenuous. But this is a study from Greece that has looked at oral B12 supplementation, 1,000 micrograms against placebo over 12 months. Important to note that the B12 level was 232 to start with, and it went up to 776. You can see in the placebo group didn't really change. But then you get an effect in terms of quality of life improves, pain score goes down, even nerve conduction improves, and that didn't happen in the placebo group. So I'd like to stop there and thank you.